So, Nair, I'm going to ask you. We saw also one of your former colleagues present some data with cabozantinib in yet another molecularly defined population, those with RET translocations.
Right. So yeah, Alex and I started this work a few years back whilst I was still at Memorial, and these RET fusions really are again in the sort of 1% club. However, and again, there's, unlike the BRAF mutations, they are seen more in never smokers, similar to the EGFR and ALK patients. But cabozantinib is one of a few drugs which has RET activity, and we explored the activity in this patient population, and what we found was that there really was a very high level of activity and durable benefit in patients treated with cabozantinib. So I think that this is another class of target that's and like as Roy said, the top 10, the hit list. Roy likes top 10 for some reason. He likes to break it down to top 10.
He's the next Letterman of oncology.
I think so, yeah.
Give me 5 minutes alone at the end.
So I think it's an active drug.
Roy, thoughts about that?
No, I would agree. I think it's, again, we know lung cancer is lung cancers. It's different in every patient, and we'll talk a bit about immune therapy, which is a catch-all, but it'd be nice to be able to divide up the pie as much as we can, and I think this is a drug that can be used in that setting.
That being said, it's a multi-kinase inhibitor, right?
Yes.
It hits a number of targets, and so it's not an easy drug to take. And in fact, I think this trial didn't prescribe it at the FDA-approved dose, but picked a lower dose,
60.
which might be more tolerable for lung cancer patients. There are other drugs, sunitinib, sorafenib, alectinib, which may be RET inhibitors. And if we could get that clean drug, that clean RET inhibitor, that might be an opportunity. Until then, we're dealing with drugs, vendetinib, that hit VEGF and hit RET and hit a couple targets and aren't necessarily the easiest to tolerate.
Well, that's the issue with any kinase inhibitor. What are there, about 500 plus kinases? And if you look at the phylogenetic tree of how they all branch out, you're never going to have one that's completely specific. Antibodies are much more specific. And another approach might be to target with an armed antibody of some sort. But again, you have to sort of get experience with different agents.
So another plug for next-gen sequencing is we looked at our patient population that when I was at Memorial who were never smokers who tested negative for everything by more standard type panels.
Negative for the top 10, right?
And negative for the top 10. And we did next generation sequencing on those samples and found about a quarter of these never smokers that were more likely to have some sort of druggable target that had a druggable target identified. Most of them were actually fusions. So I think that the next gen panels are better for picking up these fusions than FISH or IHC assays.
Were they druggable? Did you have?
Some of them we were able to treat, yes.
So it's, I guess, if you have a good phase 1 program, with agents, or you have the way to repurpose drugs, it might be very good to have that sort of thing available.
We saw with cabozantinib the ECOG trial, which was done in, we've been talking about molecularly enriched populations and using targeted therapy at a specific target in which the activity is quite remarkable. But the ECOG data was if I remember correctly, was in an EGFR wild type population.
Right, that was erlotinib versus cabozantinib versus the combination in patients wild type for EGFR, which to me is the question of, do you give focused EGFR inhibitor to EGFR wild type patients, or a multi-kinase inhibitor that's hitting, and that's they're focusing on the MET activity of cabozantinib, but also RET, also ROS, also VEGF, a multi-kinase inhibitor. And not surprisingly, the multi-kinase VEGF inhibitor was better than the EGFR inhibitor in wild type patients.
But they weren't able to correlate with MET expression because they looked for that by immunohistochemistry.
Partly because it's not just a MET inhibitor. It has activity in a number of ways.
So let me ask the panel this. If you're in community practice and you're seeing, obviously a general community oncology practice, and a fair amount of that nowadays is lung cancer because of the incidence of the disease, what are the things physicians should be testing for? What's your list of actionable genotypes in this disease at this point?
I test EGFR, ALK, ROS, first run in a week before starting therapy.
Okay.
And then I will have next-gen sequencing that gets me the other potentially targetable things, which include HER2, BRAF, RET,
the others, yeah.
and a variety of others.
Any difference?
No, I agree.
Pretty much the same. The one thing we have in our initial panel is also KRAS.
Yeah.
Now, I'm not going to pretend that we can target KRAS any better than anyone else.
Well, you
but-
can, just not successfully, right?
Right, but there are clinical trials, and
Right.
we have a Stand Up for Cancer group that's,
Yeah.
several of us are involved with that actually is looking at that. So it's nice to know for clinical trials, but in practice, I would say you have to really get that EGFR, your ALK, your ROS1, and you need it quickly. You need it within a week to 10 days. I think the CAP guidelines are 10 days, and you really need to find a way to make that happen.
Yeah, I think it's almost time to update the CAP guidelines.
What I
because,
like about a
yeah.
KRAS assay is if you find KRAS, you can stop looking.
Yeah.
Right.
It's a showstopper.
And it's usually the one that's easiest to do and comes back first.
Right.
Yeah.
And it's close to a third of the population, depending on where you are.
Absolutely.
So let's.
And again, this is on adenocarcinoma that
Right,
we're,
yes.
that we're doing this. Yeah.
So let's.